benign prostatic hyperplasia. Okay. Common occurrence, you're heavily tested on this. I think because of the amount of incidents, okay, a lot of males develop this. You'll see a lot of males in nursing homes take medications for it or have a history of it. Benign prostatic hyperplasia, bottom of 447. All right, so as an adult male ages, the prostate gland enlarges. When the enlargement of the gland begins to cause urinary dysfunction, it is called benign prostatic hyperplasia. BPH is a very common condition of the older adult. It can significantly impair the outflow of urine, making a client susceptible to infection and retention. Excessive amounts of urine retained can cause reflux into the kidney, dilating the ureter and causing kidney infections, leading to kidney damage. The client will require referral to a urologist for management. So, I know you guys mentioned kind of going over anatomy and physiology yesterday. Do we all understand where the prostate is and its function? Positive. So, let's pretend these are your testes and this is your bladder. Okay, so let's draw your two kidneys and your bladder is right here. So you'll see, okay, that on the way, let's delete this one. No. Okay, from your testes and your urine, okay, you will have a conversion, and this red is a gland that surrounds that entire tract within it, okay? Now, penis will be around here, after the tract, okay? So, when you need to urinate, what's gonna happen is the prostate, obviously, right, there's free flowing here, you can urinate. Now, when you're gonna ejaculate, right, a lot of the sperm can come back here. The prostate will make semen. Do not confuse semen with sperm. They're separate things. Semen is the fluid, okay? Sperm is more so interacted in within the fluid. And that's what makes it possible for the fluid, right, for the sperm to be able to travel in order to be able to provide conception. Now, in this case, as this enlarges, it'll continue to put pressure inwards. Okay? As that pressure builds, the flow here will be impaired. This makes it more difficult for you to urinate, okay? Makes it either difficult or that you can't hold it, right? So you'll see either dribbling, you can see the inadequacy or a weak flow, pain, okay? A lot of these things, or with bowel movements, you'll feel like this weird sensation to urinate or can't urinate, because as well as through the back of here, what's passing is the rectum. So hence the finger, okay, when you go into the anus, you can palpate the prostate. Make sense? Okay? This is why it's being able to be felt. So it's all intertwined, and they're very close to each other. Now, the prostate on average is about the size of an acorn, right? It's not too big. It should be smooth and rounded, okay? It should not be bumpy or rough or be filled with lesions. That's how they'll know something is going on. We're good so far? Okay, now, as this becomes larger, it encroaches the whole urinary system, right? Or at least the urinary tract. So the goal of therapy, as you'll see when we go here, one, could be meds or surgery. Now the meds aim is to reduce the size. And usually, this is done by hormones. that's related tamsulosin, right? Or, apart from reducing size, by, for example, relaxing or dilating the urinary tract or the prostate. Because as it relaxes, it'll put less pressure, or if it dilates, it'll open it up. That's the goal of meds usually, okay? Surgery, it's obvious. You will cut out the tissue of the prostate. Yes?
You don't do the whole thing, though, right? They just like make it smaller?
It can depend, but usually they make it smaller. Now, this can be done through a few ways. The most preferred now, and the one that you'll be most tested on, is TURP. Transurethral, so through the urethra, resection, right? Partially removal of the prostate, TURP. This means they go in through the penis, through the urethra, right, with scopes, and they can chip away at it and remove it. Okay? Yes, that's that. Now, when this happens, as they chip away through it, there's obviously a lot of debris and bleeding and clots. So a three-way catheter is put in, where one is instilling fluid, one is allowing for emptying as well. Okay? There's a continuous bladder irrigation. A three-way catheter is put. And this is continuously flushing out the bladder and the prostate, so that way it's not getting clotted and occluded.
Is that the coude?
Huh?
Is that the coude catheter or not?
The coude is more so like a stiff, angled one to be able to get through when it's not possible to get through. So no, it's a continuous bladder irrigation, but you use a three-way catheter. We're gonna go over this a little bit more in detail, but just so that we get the visuals of what's going on. Yes? Okay? So that is the purpose here. Now, should this remain obstructed, as it says, the urine will eventually backflow to the ureter, right? The ureter is basically the line from the kidney to the bladder. If your ureter is dilating, it can cause a lot of pain and discomfort, especially in the flank. If your kidneys start filling with it and it's backed up, you'll feel this flank pain. Okay, as the kidney has urine, infection will develop, all right, and then it starts to become fluid filled, very painful, and a barrage of then problems. Yes? Okay. So, I see the purpose of the CBI. I'm like, it's difficult trying to visualize it, but you can see it through it. Not long ago, I had a man who arguably, I didn't get to see the biopsy, but it was already suspected from it, probably had bladder cancer. Came in finally, 25 years, hadn't seen a doctor. So he had no medical history, and he was having like fatigue, weakness, and eventually came in because he was having difficulty, he couldn't urinate. And in the ER, I guess they forced the Foley. And then he started eventually peeing out like red urine, right? Not even blood, like red. And so I asked him, like, when did you start peeing blood? And he's like, I didn't. He's like, until you guys here. But when they gave me the catheter, he's like, I've never peed blood. So it was hard to know what was going on with him, but when you palpate it here, I could feel like a mass, like right here on the bottom, right where his bladder's at. And when we were trying to keep track of his output, I would like bladder scan him, and I could see like something. It wouldn't look as how it needed to on the bladder scan. So I was trying to scan him, and the number was like off or whatever. And so people were flushing him, right, to like try to keep it going. But for mine, I eventually noticed that he stopped, like he wasn't really having output. So I tried irrigating, and I could tell it would be a little bit difficult, and I would try to like aspirate it, and eventually my syringe from like just inflated his balloon, and I was like moving it in and out to try to like position it, and I was flushing with another hand, and eventually I would try to like pull out, and it would be like harder, it would stop flowing. I wouldn't get as much as I would put in. And when I eventually started seeing, when I would like fidget with it enough or trying to disinflate it and whatnot, like maneuvering it, I eventually started pulling out like literally clots. So he was clotting inside from his blood.
Whoa.
So he was retaining too much. Doctors weren't there, he had no medical, it was like a show. But anyway, eventually they started transferring him, and when the doctor finally came, he gotta move on everything. It's like emergent. This guy's not really outputting. He's clotted now. They thought of a coup or a continuous bad, like he needs more. They kept on calling him, like, dude, like the guy's like not peeing and like we're not like nothing's moving. He has no orders. But anyway, urinary output, please make sure you're checking it, okay? Intake and output is so simple, and I can tell you stories, more than a handful of people, like, again, CNA's not reporting that there's no output because they empty the Foley's, right, the bags, a lot of the times. So, I sometimes see them empty, and I'm trusting that they're documenting outflow. And I've had cases where CNAs report 700 or whatever because they're just charting. They just chart. Right? They're like, we're emptying them, fucking we empty it. They just put, they're used to putting their typical 5 to 700. You do that? So,
I've seen a lot of them.
yeah, it's that. So I always level with my CNAs, and I always tell them, don't bullshit me. Because if you do, then I'll make a mistake. At the end of the day, right, like we're all here in it together. If you tell me something's wrong, I'm not gonna tell you anything for it being wrong, but then I know how to fix it. And I've had CNAs not tell me the truth about it. This lady, right, semi-comatose, hyperventilating, she's sweating, her heart rate's going up, I don't know what the hell's wrong with her, right? And she looks like she's having like almost like autonomic dysreflexia. So I told her, I was like, did you empty the catheter? They used to work in teams in the subacutes, right? She's like, yes. And then I'm like, how much does she output? She said, it says it on the paper, right? Like I don't recall. She checked the paper. So it says 700. Did you get 700 out? It was my partner who emptied it. And then they need to do that, a little blame game. So like, grab your partner. And then she comes, did you empty it? She looks at her, they're looking at them, at each other. And that's when I told you, I was like, don't play with me. I'm like, you're not in trouble or anything. I was like, but something's happening. Foley's dry. Did you empty it or not? No. Okay, 10 hours later, I'm like, this lady, arguably, at least since the beginning of my shift, has not outputted 10 hours of not urinating. Okay? I was like, don't do that, because then I can't know what's going on with her. Now, I don't know if the Foley's clogged or kidney functions in her, like, I don't know. And if you're telling me she's outputting, it looks dumb. They're like, okay. I go, I disinflate her balloon, and the moment I disinflated her balloon, she starts gushing from the vagina. I did another Foley, and she just starts outputting like crazy. And immediately, heart rate comes down, her temp starts to come down, her breathing eases. Make sense? So, intake and output. Make sure people are taking in water or fluid to keep track and how much they're outputting. You need to be able to keep track of it. It's basic function of what's happening to your fluid. Okay? Cases where people are, again, semi-comatose and they're not drinking water. There's no water order, same thing. I caught it and the patient was always like 94 over something. Would creep into the 80s systolic. Okay, and the night nurse will tell me it's their baseline. That's how they are. That's how he is. Yes.
Sorry, what did you say? She was like, how did you say she was acting when she was like not urinating?
So if people are paralyzed from like I think T4 or 5 down, they may not, or up, sorry, they may not feel their bladder. They don't really have sensation. So when they either are constipated and have a lot of stool in the rectum, or their bladder is full, or they're uncomfortable sitting, some stimulation down there, there's no reception. So then there's like a dysreflexia that happens, and it signals to the brain, and it just triggers their blood pressure to skyrocket, their breathing rates are going abnormally high, and they pop a fever. It's just an automatic reflex that's happening in the brain from the discomfort, but they don't feel it physically, but it's happening to their body. Yes.
That's not only from urine though, right? It can be like any discomfort.
It can be any discomfort. So that's just not aware of. So the thing that you gotta do is, again, find out, is it not urination? Is it that they're constipated or have poop? Or is it that they're leaning on something a certain way? So you reposition, check the bladder, you have to figure it out. That was a test for me to get hired at the subacute, by the way. That was a test question. She gave me a scenario, list of meds and everything and describe autonomic dysreflexia. And she's like, what do you suspect? And then I said, she's like, what do you do? And I told her, I said, I use a Foley on her. And then she's like, okay. She's like, she's urinating. And then she's like, how much would you let come out? I told her half a liter, in my opinion. I said, and then I do it again in 15 minutes. She's like, why? And I was like, because even if she's retaining, if we let out too much urine, she will go into hypervolemic shock. Okay? So things like that matter. And that's what she told me I got hired. She's like, because most people don't know and don't know how to troubleshoot, they're not aware of what can or what's called, they won't try to figure it out. So the first thing is always like, they don't know. So it's good to be savvy, and again, this understanding again what's happening, and I try to hopefully instill that to you. What's happening, what do you see, what do we do, what can be a complication, such as a shock. So you make sure you don't overstep. Make sense? Okay, so intake and output. Very basic, very easy, extremely important.
What's that term you're using? I forgot.
Autonomic dysreflexia. I don't know in what this should be covered. I would assume maybe musculoskeletal during fracture. I'm not sure. I'll try to see if I can look it up. It's asked here and there. I think it's important. A lot of people don't know about it though. I'll try to see if I find it. In any case, we understand urinary function through BPH, right? Okay. Next point. I'm gonna erase this. Next point. So risk factors. I need you to know the risk factors. Genetic predisposition, Black ethnicity, increased consumption of coffee and caffeine and coffee. Increased age is a big one. Smoking, chronic alcohol use, sedentary lifestyle and obesity, and a Western diet, high fat, minimal protein, carbohydrate, low fiber. And diabetes, heart disease. Please know your risk factors for this disease. Okay, the Western diet, sedentary lifestyle, age, alcohol, smoking, caffeine. You must know this list of risk factors for BPH. Okay? All right. Expected findings. So how do you know? The client may be asymptomatic, second bullet point under expected finding. Okay? The client may report manifestations of urinary tract findings, such as urinary frequency, they're peeing a lot, urgency, hesitancy, or incontinence, so they can't hold it in, they can't let it out. Okay? Dribbling, post-voiding, diminished force of urinary stream, incomplete emptying of the bladder, or they're straining with urination, or hematuria, right? It's like blood tinge. Labs, we're gonna do urinalysis, BUN creatinine, my sister kidneys and the urine, and then diagnostics, like we said, prostate specific antigen, digital rectal exam, and ultrasound if needed. And we know how to obviously perform those. Now let's look at therapeutic management, page 448 and 449. So we'll go over 3 important medications. Now remember, the tests are comprehensive. That means that a lot of people can sometimes fire back and tell me like, well, this isn't farm, why don't you ask us about tamsulosin or finasteride? Because it pertains to BPH. You'll see farm questions, they pertain to it on your adult Med-Surg proctors as well. Now, I'll make it easy for you in the sense that I won't ask you about tamsulosin or finasteride outside of what's in the Med-Surg chapter. Does that make sense? What we're about to go over right now that you see here, that's what's fair game for you to see on your test. Now, is that how the proctors work? No. Okay, because you've already taken pharm and passed it. Make sense? So everything goes. For my test, I stay within the Med-Surg chapter that we're studying so that you can have all the information in one place. Okay? First one, 5-alpha reductase inhibitors. These are your finasteride and dutasteride. You'll mainly see finasteride. Okay, so meds. Finasteride. Now, key things, general considerations. Lower dihydrotestosterone, which decreases the production of testosterone in the prostate gland, and this will cause a reduction in the size of the prostate. So by reducing production, testosterone production, this should reduce prostate size. Okay, now nursing actions. This is important. This is a process, right? Starts, stops, begins to stop testosterone production, and over time, this gland should reduce in size. First key point there, remind the client that it can take up to 6 months before the medication effects are evident. 6 months to become evident. Now, a question I see, and they'll say, what indicates the need for further teaching, right, on the medication? Is, I'm glad I'm starting this medication. The stage is like, right, I'll start feeling better next week, or I'll see the effects next month, right? So, if that's wrong, right, it needs further teaching because it won't take a lot of effect until a few months in to begin. Okay? They use that question too on antidepressants. They begin having an effect at about 6 to 8 weeks. It's up to 3 months for a full therapeutic effect. And 3 days later, they tell you, like, I'm so much better, I feel less depressed. It's a lie. Good? Next point.